This is Social Work Month. Our theme is social workers are essential. And for all the social workers who are viewing with us today, who are in attendance with us today, you are essential. Remember that the work that you do, you are essential. Every role that you play, it doesn't matter where you are in your career, you are essential. And so always be reminded that you are essential. So today we're in for an awesome treat. Today we honor National Women and Girls HIV Awareness Day. We have a panelist of 5 experts. Yes, 5. We have 1 moderator, Dr. Foster, and 4 of our panelists that you will hear from later. But now I will turn the mic over to Dr. Amy Traylor. She will do a hearty welcome, and then she will turn the mic over to Dr. Pamela Foster. Dr. Traylor.
Pleasure to welcome our moderator, Dr. Pamela Payne-Foster. Dr. Foster is a preventive medicine public health physician who currently serves as a professor in the Community and Rural Health Department at the University of Alabama School of Medicine on the Tuscaloosa campus. She's also the Deputy Director of the Institute for Rural Health Research. Dr. Foster's current research area of interest is the study of HIV/AIDS-related stigma among rural African Americans in Alabama, particularly in faith-based settings in rural Alabama. As an activist, she and her husband, William Foster Jr., founded a nonprofit called AFRAM South Incorporated, and they address several health issues that African American families face. Through that nonprofit, she has published 2 books entitled Is There a Balm in Black America and Practicing Prevention. They also sponsor a community radio station, WUMO, which if you're interested, you can find online at WUMOLPFM.org. And Dr. Foster, we are just so appreciative of your time and look forward to your moderation of what will absolutely be a fascinating and important panel discussion. Thank you for being here.
Thank you, Dr. Traylor, and I'm so excited to be here as a part of this panel discussion talking about HIV/AIDS in women. As you know, we've already said this is national. Today, March 10th, is National Women and Girls HIV/AIDS Awareness Day. So this is appropriate to have this session. And we're also in the midst of the social work month. My disclaimer is I'm not a social worker. But I'm married to one. So I hope that's close enough. So let me get started introducing the panel, and we've got an exciting lineup of questions. And please, this is interactive. Please feel free to put your questions in the chat as we move along with this session. So our first panelist is Gina Brown. She's the Community Engagement Manager with Southern AIDS Coalition. She has worked in the field of HIV/AIDS for 18 years, and has been living with HIV for 26 years. She graduated magna cum laude from Southern University of New Orleans with a Bachelor of Social Work, another social worker, and with a minor in history in 2011. She received her master's degree in social work in 2012. She's a former member of the Presidential Advisory Council on HIV, PACA, and she has served on numerous boards and committees. She currently serves on the Sister Song Board of Directors, Black AIDS Institute Board of Directors, and the Well Project Community Advisory Board. Let us welcome and thank Gina Brown for being on this panel. Our second panelist is Dr. Karen Johnson, who is one of your own here at UA School of Social Work. She's an assistant professor here in the School of Social Work at University of Alabama. Her primary research interest focuses on decreasing the risk of HIV and other sexually transmitted infections among impoverished women with co-occurring risk of criminal justice involvement, homelessness, substance use, intimate partner violence, and depression. She completed her PhD in social work at Columbia University and a postdoc fellowship in global mental health studies and Implementation Science at Columbia and New York Psychiatric Institute. She has served as a co-investigator on several studies, and prior to, which is I find the most interesting part of her CV, prior to completing her PhD, Dr. Johnson worked as an administrator for approximately 20 years in multiple practice settings. Thank you, Dr. Johnson, for being on the panel. Next is Dr. ZENORIA PRUITT, who is MS, MPH, and PhD. She's a native of Mobile, Alabama, and has resided in Birmingham, Alabama for the past 22 years. She has received numerous degrees and certifications from several universities, including Stillman College, Tuskegee University, Walden University, and University of Alabama at Birmingham, and University of South Alabama. With over 30 years of experience in biomedical research and laboratory practice, Dr. PRUITT relocated to the Magic City after accepting a position at UAB. She currently conducts research within the Department of Medicine, Division of Infectious Disease, and UAB 1917 Clinic. She's published many articles and scholarly events, but the most important fact that I found in her bio that she has visited 49 of 50 US states. She's involved in a variety of boards, including Birthwell Partners, which is a group of community doulas. She's also has been a mentor and advisor for the Birmingham AIDS Outreach, Big Brother, Big Sister of Birmingham, and 1917 Clinic, as well as their patient advisory board. She's also involved in a variety of other civic activities, and she loves to spend time with her husband, reading books, hanging out with friends, and playing with her baby dogs, 2 of them, Lala and Benjamin. Last but not least is DAFINA Ward, who is an expert in program and organizational development with a focus on community health initiatives. She currently serves as executive director of the Southern AIDS Coalition, SAC. She previously was the director of community investments and also interim director, where she raised more than $10 million and has raised more than $10 million as a grant writer in funding for community-based programs. She is an adjunct professor in nonprofit management at the University of South Carolina in Beaufort, where she currently lives with her husband and 2, she says here in her bio, 2 brilliant daughters who obviously take after their mother. I do want to add that she's written extensively, including works, op-ed pieces in the Washington Post, the Lily, the Role Reboot, where she was also a 2017 Ford Foundation fellow. So thank you to our panelists. And let's get started with asking these questions. So first I'll start with the first question. What is your current role in the kind of work you do? And many of you are social workers, so if you can kind of put in what you do as a social worker around this work, that would be great, since we're talking about Social Work Month. We'll start with you, Gina, Ms. Brown.
So first of all, thank y'all for having me. Hello, everybody. My current role, I'm the community engagement manager at SAC. And I think even though I don't practice as a social worker, I use a lot of my social work skills. So I meet people where they're at. I'm non-judgmental. I still follow the social work code of ethics, even though I'm not, working as a social worker. I think it's important to give people autonomy and agency over themselves. So I'm there just to help guide or to help navigate some tough things that you may be going through. I do a lot of my work on the ground with people living with HIV. So I deal with everything from homelessness to domestic violence, because we know all of those things are impacting people living with HIV. And as SAC, we are really, really in tune with the community we work with. And as a social worker, y'all know that you have to be in tune with the community you work with. Mm-hmm. The community understands when you're not authentic. And that's the most important thing that I've learned over these years. So yes, I am not working as a social worker, but I still use my social work skills.
Thank you. Thank you, Ms. Brown. Very insightful answers to that question. I'm going to switch over to DAFINA. Ward, can you talk about your current role and the work you do?
Sure. Good afternoon. It's so great to be
Afternoon.
with all of you. I am not a social worker by training, but I think I'm a social worker in my heart. And I try to show up in that way in the work that we do. And as Gina mentioned, at the core of our culture and our mission at SAC is about helping to improve the lives of people. So very much in alignment with the work of social workers. And I think, you know, our work, our mission is around ending the HIV epidemic in the South. And we recognize that we can't do that without addressing the myriad of needs that people have in our communities and the range of inequities and challenges systemically that our communities are facing. And so that is how we show up through our grant making, our leadership development, our capacity building work with community-based organizations as well as public health entities, and all the other work that we do, our policy advocacy work. We recognize that in order for us to have shifts and changes in the way that things are implemented in our communities and the standards and expectations, then we have to have policies that support that. And so there's a lot of barriers in place that have to be eradicated for us to get where we need to be. And so that's really at the heart of our work. And I would say that also, in addition to that, in my role as an executive director, my focus really, in addition to meeting our mission and working with our stakeholders and our partners, it's also about establishing a culture within your organization that really is also about affirming people. And I call it trauma-informed management, but recognizing that people come with a range of challenges and lived experiences that are going to show up in different ways, and that we have to acknowledge that. And so I think that any good manager or organizational leadership also has to think about a framework of staff engagement and support, that also recognizing that that part of your role is to support people and to support them in getting to where they want to be, and to not do harm in the process of managing folks in their work and in the aspects of their lives that they bring to their work.
Okay, thank you very much. Could you follow up a little bit? I like that term you use, trauma-informed management. I've never heard that. Is that a new term or something you came up with on your own?
I'd love to say that I coined it. I probably didn't, because there's nothing new under the sun, but I started saying it several years ago. I've been a remote manager for a number of years. I know for a lot of people it's been new during COVID, but I've worked in a remote environment exclusively for about 6 years. And recognizing, especially in a remote space where people are working from home, you come to see that folks are dealing with a whole lot of stuff. It's really hard to separate personal from professional when you're working in the corner of your bedroom, right? And so really started to understand as a remote professional, and before that as director of prevention at AIDS Alabama, and working with the staff, most of which were living with HIV, but also impacted by a range of different challenges, that we can't separate people and their lived experience from the expectations that we may have around work deliverables. And how do we find common ground to be respectful of what people are experiencing and supporting them, and also providing space for professional development and growth. So that's what I mean by trauma-informed management. And it's something I don't think in our work culture in general that we really talk about and really support people around. And so it's very important, I think, in establishing level of accountability and support as well.
Thank you so much, DAFINA. Dr. ZENORIA, can you tell us a little bit about your current role and your work?
Hi, how you doing?
Good to
Hi,
know.
everybody. Yeah, sure. Basically, I am not a social worker by trade, but I am a researcher. And, piggyback on one of the things that Delphina said, is one of the things that controls how society gets its needs met and how society looks at and views health is by policies. And one of those ways to change policies is through research. So research is basically our first thing you come to, because you want to make sure that when you're changing a policy or conducting anything within the society and the community, you have to first evaluate the community, the needs of the community. It's just, oftentimes I find that a lot of researchers will go into a community with expectations of what they think the community needs, but not be a part of the community. And as researchers, we have to take the time and the effort to act in a social work manner of going through the community and figuring out what the needs of this community is. For instance, in our local, what we just had as far as the pandemic, the coronavirus, it was you know, at first everybody said, oh, you go through and you drive through these testing facilities and you drive through now to get your vaccines. Well, we have members of our community who do not have transportation, who utilizes public transportation. So as a researcher, we have to go through and figure out what are the needs of the community, how to get the needs to the community, and to figure out a manner which would make sure that it's equitable between all the communities. We want to make sure that, for instance, is the vaccine acceptable to everybody, accessible as far as the testing and things of that nature. So research is done by those manners. And so research has to be, I think, at the ground level of any social work, and to figure out the needs of our community. And that's what I think is the most important for me.
All right, thank you. Thank you, Dr. Zenoria. Am I pronouncing that right? Zenoria.
Zenoria, yes.
Zenoria.
You're doing a great job.
Great. Great. And we have our next and last panelist, Dr. Karen Johnson. Can you talk a little bit about your role and your work?
Yes, thank you, Dr. Pam, who's a mentor of mine. And thank you so much for having me here today. It's a sincere pleasure. I am a social worker, and I have both my master's in social work from Hunter University in New York City, and also from my PhD, as you heard, in social work from Columbia University. And it's a sincere pleasure to be here today. I'm actually glad that I got to go last, because I was thinking right after each person's talk, oh, I want to say something like that. And so in terms of what I'm doing today, I do research as well, like Dr. Zenoria. And I was thinking about the term research, and I think I partner with communities that I'm serving through research, right? And so just like was shared before, it's a true partnership that I try to forge with populations that I serve. In my research, Dr. Pam mentioned implementation science, that I have training in implementation science. And what that basically means is trying to figure out with all parties, I work with women primarily. So women at risk for HIV and AIDS and other sexually transmitted infections in the justice system, primarily Black women who also use drugs. So I work with that population, but I also work with the population in organizational settings. So the frontline staff, the executive directors and others, and together try to understand those factors that make it hard to bring evidence-based interventions, like whether it's like a program that is evidence-based and says this reliably works, or an intervention that reliably works to those settings. And so that's really what I do. I work in partnership with populations. And as Dr. DAFINA was saying, I do think that it's such a critical piece to not make assumptions and to understand that employees and the population, whatever that population is that we're working with as social workers, that people are bringing themselves to the table, right? And so that means that organizations are oftentimes, it's a great opportunity to deliver services, but also organizations and the nature of the organization, whether how it's structured or just the things that people are dealing with who are trying to fulfill the goals of the organization, that sometimes can get in the way of well-intended care. And so that's really a little bit of a snapshot about the work that I do.
Fantastic. And I love that everybody sort of had the common thread in everybody's roles as people, keeping people at the center of what you do. I love that. Gina, you started out with us talking about really having good people skills in order to be a social worker. That's what I love about social workers. They have the best people skills. But also policy. DAFINA talked a little bit about policy as a part of the work she does, and also research. And I love that the two researchers made research sound fun. Not as sometimes when you hear the word research, it sounds boring and horrible, but it sounds like the type of research they're doing is relevant and exciting. So I'm glad to hear them frame it in that type way. Please, people in the audience, send your questions about, if you have any questions about the roles and the work that they do, particularly as social workers, please put them in the chat. especially students who are on this webinar, because you're probably beginning to think about what you might want to do and what would I do after I graduate with my master's in social work or BS in social work. And so this is a time to ask some of those who are working in the field those questions. So we'll wait to hear from you on that. We'll move on to the second question, which is really the impact of HIV on women, since this is a National Awareness Day. And Gina, I'm going to start with you, the impact of HIV on women. And I know you have a lot of expertise in this area.
Yes, I do. Anyway, I know we don't hear a lot about women when it comes to HIV. We still hear about gay, bisexual, and same-gender loving men and transgender people. But women are a big part of people who are living with HIV, especially in the South. You know, there are over 300,000 of us living with HIV. And it's so impactful to the point that when women are diagnosed, it really impacts their social settings, right? So they stop dating, they stop going out, they isolate. HIV looks really, really different in women than it does in gay, bisexual, and same-gender loving men. Women tend to be the caretakers of the house, right? So we take care of it. DAFINA will tell you I'm guilty of this forever, but take care of everybody before we concentrate on ourselves. So we tend to have worse health outcomes with HIV because we're not taking care of ourselves. HIV impacts women in such a way that, and it's really hard to talk about it without getting emotional because a lot of times people don't want to hear those statistics. You know, even when you're talking to policymakers and researchers, it's really hard to get people to understand that for a woman, there is no risk factor. Our risk factor is that we're women. I can sleep with 100 men. I can sleep with a different man every day and use a condom and not be at risk for HIV. And I can be in what I think is a mutually monogamous relationship and be at what we would know would be risk because maybe he's stepping out. Or maybe I'm not as mutually monogamous as I'm telling y'all. Maybe I'm doing some things. So when it comes to, you know, and that's why we really can't get a handle or get women to get tested in high numbers because we always come and tell them that they're at risk for HIV. They're not at risk because of their behavior. They're at risk because they're women, if that makes sense.
How about you, DAFINA? Discuss the impact of HIV on women.
Well, I can just say amen to everything that Gina said.
Right.
And, you know, I'll illustrate it with the story of someone who I always think of on National Women and Girls HIV/AIDS Awareness Day, a dear friend who we lost to complications related to her HIV diagnosis. And she's a woman who was living with HIV, did not know that she transmitted HIV from her husband, didn't find out that she was living with HIV until she was in labor delivering her son. And at that time, while it's very rare now, her son also was born living with HIV. And now we have a range of interventions that prevent that from being common. So she hadn't been in prenatal care because of socioeconomic challenges and lack of access to health care. Found out she was living with HIV due to her husband's infidelity, which Gina talked about. Now is living with and raising a child with HIV, and later has cervical cancer. Was ashamed of living with HIVs. That kept her from going to support groups for cancer. That shame also kept her from sharing her HIV diagnosis with friends and family. I only found out because she saw me say something about ending HIV stigma on Facebook, and she disclosed to me via a direct message on Facebook. And I'm so thankful that she did, so I could try to help and support her. But that story is all too common. That story is all too common, where women are walking around in shame, unjustifiably in shame, but completely understandable because they don't know how people will respond to their HIV status. And the fact that she felt so ashamed of her HIV status, she didn't think she was worthy of support around her HIV or her cancer diagnosis. And that is what we're dealing with. And women are the caregivers. And so often for those who work in community-based organizations serving women living with HIV, you know that when a woman comes in for services to see her social worker or case manager, that HIV status is like the 7th thing on her list. It is not the top priority for her. She don't know what she's gonna eat, where her and her babies are gonna sleep, where the bill, how she's gonna pay that light bill, how she's gonna get out of that situation that is violent and scary, or she is struggling and coping and dealing with substance use. Like, there are just so many things. And so I think that's the reality of women who are living with HIV. And if we can dispel of the myths around HIV, this whole idea that anybody is a walking, that you somehow need to be ashamed because of your status. It's a health condition, and that folks have been made to feel as though it's some type of badge of shame. And social workers hold the power of destigmatizing and to truly shift the way that someone sees themselves. So I want to name that as something that women living with HIV need: social workers who can affirm them and speak positively to them and destigmatize the condition of HIV.
Thank you so much, DAFINA. And you really set me up to, I'm going to shift a little bit with the last two panelists, because the whole idea of dual diagnosis, you talked about HIV and cancer. Because she had HIV, she delayed her screening for cancer. Cervical cancer is preventable, as we all know. And so the delay came from the shame. Dr. Johnson, Karen, could you talk a little bit more about that, with the overall health and wellness, HIV being just a piece of it?
Yes. The term that comes to mind is intersectionality. And I wanted to share that term with you because, exactly as you just mentioned, Dr. Pam, and what Dr. DAFINA mentioned, the same factors that increases a woman's risk for HIV are the same factors that increases a woman's risk for lots of other co-occurring risk factors. And as social workers, we're trained to think of the person in their environment and systems, right? Early in the days of social work, of the HIV crisis, and for those of you who are been around for a while, you know that we've been living with this crisis for 40 years. And the fact that it's a crisis still 40 years later is pretty telling, right? A lot of times the problem was located in the person, and rather than thinking about those societal risk factors, right? But as social workers, we step back. I see someone put in the chat social determinants of health, and we are trained to think about those factors that increases the risk, right? So the population that I work with specifically are women in the justice system. And over the last 2 years, I've interviewed 50 plus women, a number of them in New York, and then a number of them here, mostly Black women. Of the women that I've interviewed, 40 some of them are Black. Why am I focusing on Black women? Because we got it. It's an epidemic within an epidemic, right? So for every 10 women who are diagnosed as HIV positive, how many of you guys want to guess how many are Black? Nationally, it's around 6. Within the South, as Ms. Brown said, it's even more concentrated. We're looking at 7 or 8. When you're talking about a younger population, a recent paper said 9 out of 10. When you're talking about a younger population, the numbers are shockingly high 40 years later, and the co-occurring diagnoses are usually substance use. Of the studies that I've done myself or been a part, approximately 80% of these women were sexually abused as children, high foster care placement, we're looking at depression, but at the same time, because the story is also a story of resiliency and survival, right? And so when we think of co-occurring risk, I think it's important to also think about those factors alongside social workers being an active and a vital part of the answer, partnering with, not objectifying, right? But the factors that cause women to survive. And so these women are wonderful. Another thing I want to mention, and then I'll stop here because I could go on for a while, is that for women, most of the pathway to risk is heterosexual sex. Still to this day, as was shared, the bulk of the diagnoses are occur because a woman goes to a doctor's appointment. She's not feeling well, and then she thought she was in a relationship that was monogamous, perhaps. Or a lot of times women will say, my partner doesn't want to wear the condom, I want to wear it, and I'm trying to negotiate that. He slipped it off during sex, and I discovered it afterwards, 40 years later. So there's a lot of factors, social determinants of health and other factors that come together to create this crisis 40 years later.
Yes. Thank you so much. And thanks for slipping in those statistics. I had some here. 7,000 women diagnosed in 2018, 122 women diagnosed in 2018 here in Alabama. And of those, Black women are 9 times much more increased to have HIV, you mentioned that, than those of their white counterparts. So thanks for slipping that in. I do want to go to the chat before we go to Dr. Zenoria. Someone said something about they've had clients that say rather than having a terminal illness, cancer, they're more open about that than receiving treatment for the HIV diagnosis. So that is heartbreaking. That was directed to we keep saying Dr. DAFINA, that must be prophetic. But yes, that is because all of, we know that HIV is people can live a long life, testimonies in front of us, a long life with HIV if they take their medicines on a daily basis. We also have other preventive treatments. We might talk about PrEP and the lack thereof of women getting PrEP. That's prophylaxis treatment if a partner or someone associated with a person with HIV is at risk. So we'll get into that a little more. But Dr. Zenoria, can you talk a little bit about the impact of HIV on women, particularly you're at the 1917 clinic, one of the largest HIV clinics here in Alabama. Always a little ahead of the curve. Has a new facility, I hear.
Yes, brand new building.
Have y'all moved in? Yeah.
We have. It's over. It's like huge. It's 3 times what we had before in our other building.
Wow.
So, and we also are sharing the building with Birmingham AIDS Outreach. So it really is this great marriage of community and with healthcare. Mm-hmm. And then we also have, our level of research here. So we're like, I call us a one-stop shop. You have everything from dental and all of that social work team here, everything. Mm-hmm. So we are pretty much cutting edge, which is strange. But as far as getting back to the impact of HIV on women, I was sitting there reading some of the comments on the side, and Kimberly, thank you for that comment. I remember talking to a study participant one time, and her and I was in a conversation, and she told me, I'd rather have cancer than I have HIV. And I kind of looked at her and I said, I'd rather have HIV than cancer. I'd rather have HIV than diabetes. And she said, what are you talking about? I said, I'd have to take a pill a day and I'm good. I said, but I don't have to have the worry of having, an amputation because of, my diabetes, or I don't have to worry about, my cancer moving to a stage 4 and ending my life. And she never thought about it that way, because her thought was that this is another confounding issue that I have to deal with. As far as, when Delphina pointed out, many of our study participants, our patients in the clinic, they think about how to get food. How am I going to take care of my child? How am I going to pay for the rent? How am I going to get the mortgage done? It's all of these issues that I think we as women, we spend more time with nitty-gritty little things that we have to think about, and then to add that issue on. And she just thought about it as another thing to add on to my plate. I'm really, and I have to say this, I applaud our social work team here at 1917 Clinic, because we have a village approach. You know, and there's one of the things I think is fantastic about them is that they make sure that they are a part of this woman's or person's village, that I can help you find needs and food and whatnot. Even when we were going through the, the pandemic that we're still going through, we had phone calls, out the wazoo of people just trying to find food, just basic food. Many of our participants and our patients were scared, knowing that they already have, immune compromise, that they did not want to go outside of their house. So how am I going to get my medication? How am I going to get food? How am I going to pay for the rent? Those confounding issues. And then, and like you said, some of them are also dealing with cancer and diabetes and heart disease and blood pressure and things like that, which, statistically and through research, we have found that become, unfortunately, high prevalence in those who are HIV positive, oftentimes because, something people don't talk about, which is the stress that is around the shame. I don't want anyone to find out. What happens if I find out? I have had women that I've talked to on Monday or Saturday, whether they are preparing food for their whole family and they have the best macaroni and cheese than anybody in the family. And then someone find out about their diagnosis on Monday. And then by the time the next weekend comes, everyone is eating off paper plates and they're not allowed to touch any children, or they're not allowed to touch any food. Could you imagine the shame? Could you imagine the guilt? Can you imagine the stress of all of that weight and burden on you? And then also, as many people have said, and we have had in the latest in the topics of the news, a lot of times women carry the burdens of our society anyway. Add all of those, and then confounding issues of cancer or whatever else they have. That enormous amount of stress. I mean, think about someone's mental capacity. Could you handle that? And the resilience that these women go through as far as having all of that and still be able to dress themselves, get up, take their medication, get to their doctor appointments, get the children to where they need to go. I mean, oh my God, literally marvel at the women that we have in this clinic. I mean, I have literally sat there and said, hats off, because I couldn't do it. Ms. Brown, I couldn't do it. I mean, I thank you for just showing me how to do it, because I just, you guys are like trailblazers.
Yes, you could. You could.
Yes, you could.
Do it. You could. You know why? We do it because we have to do it. And I wanted to jump in it because I want to make myself available. Definitely say I put myself out there too much, but I'm going to say it now anyway. But if you come across a woman in your clinic who doesn't have any other support and there's nobody in Alabama they want to talk to, send them my way. Because there's no reason that any woman should be in any clinic in what year are we in, 2021, and not have support. We need peer advocates in clinics so that we can make sure that we're addressing the needs of women that social workers may be too busy to address.
And Gina Brown, that's so important, especially in the South, because we don't have a face for HIV/AIDS, women with HIV. So we really applaud you and thank you for that, because we need more of that so that people can feel that they have the support.
And y'all have some amazing advocates in Birmingham.
Birmingham.
Right?
We do.
Yeah, I work in rural Alabama, so it's a little tougher.
We would check with them first to make sure we can give their names.
Correct.
But that would be even better, because that person can actually go and meet the person.
Right. We've got a lot of questions about PrEP and about stigma. So I'm just going to kind of open it up for the panel to think about those two areas. Can someone just explain? I said prophylaxis, but it's pre-exposure prophylaxis is a prevention tool that we have now. It's been around for at least, 4 or 5 years? And women have not really availed themselves like the men have. So we can talk a little bit about maybe why. And Dr. Karen, you want to explain it?
Sure. And I also want to comment about stigma as well. So pre-exposure prophylaxis, and there's also something called post-exposure prophylaxis. So it's PrEP and PEP, and you guys might have seen some of the commercials. It goes by other names on TV, but I think the reasons why, I'm sorry. So what does it do? So what the purpose is to take it, and part of the key is to take it consistently in order to prevent pre-exposure prophylaxis, and post-exposure prevent transmission of HIV. And pre-exposure, you take it prior to having sexual intercourse, and then post, you take it after after intercourse that was not protected, right? They use the term condomless sex, right? And so the goal is to take either pill, you're not taking both of them, either planfully, pre-exposure, or post-exposure if you have intercourse and it was not protected. So I wanted to mention of the women that I spoke with, so the latter group, 21 women in Tuscaloosa and Northport, mostly African-American women. Of the women I spoke with, I asked everyone if they've ever heard of PrEP. I think only one of 21 had heard about it, right? Or even that there was a pill like this. So because it goes by other names, have you heard about anything like that? Nope, never heard about it. And so part of it is someone earlier, I can't recall who, I think it was ZENORIA, was talking about access to COVID care, right? Testing and vaccines, and the messaging, right? You hear on the news, they're talking about how do you message it appropriately. So it's a secret that's not getting out, but also those who know about it, there is a healthy bit of skepticism, right? For individuals, not the ones I've interviewed, because I mentioned a lot of them are not even aware that it existed, but others are worried, right? Is it something that is going to hurt? Is it designed to hurt Black people, for example, which is some of the same questions that you hear about the COVID vaccine as well. And so there's a fair bit of research being done around, well, how do you get the word out? How do you get it out in a culturally appropriate and way, partnering with peers, partnering with others in the community so that people know and at least have informed choice. If someone chooses not to take it after that, then, you know, then we can talk about that as well, but at least that people would know. I also wanted to talk about stigma just for 1 second. Right before this call, I was on a conference call with one of my research, an organization that I do research with in Selma, Alabama, and they mentioned that it's a AIDS services organization that's designed to work with people who are either HIV positive or those at risk of becoming HIV. And for many who are HIV positive, as Dr. Pam says, the stigma is powerful, right? One of the things that they do to this day is they hide the medication strategically in the community so that the person doesn't have to come to the site to pick it up. In order to, because when you're talking about rural, more intimate settings, right, that means everybody knows, right? And we'd love to get to a place where you could say HIV, and I'd rather have HIV than cancer, but it's still not there, right? And so organizations are trying to figure out how to provide support in ways that honor someone's need for privacy while getting them the services that they need.
Thank you, Dr. Johnson. How about that PrEP? I know marketing was also an issue. The way it's marketed was to men, mainly, not women. Can anybody?
Well, I was about to piggyback on that real quick. Most of our women that we have had on the study that I'm a part of and direct here at UAB, Women's Interagency HIV Study WISE, we've done extensive questioning about this. A majority of the women, when you look at the marketing for Truvada or Descovy, it was white, gay men that they marketed to. So they didn't even think it was, they needed it or it was a part of what they needed. And then to now, for some of them to know, okay, well, I can ask for this. So they'll go to their healthcare providers, and oftentimes their healthcare providers have not been educated. So you're asking an individual who sometimes I've heard and had many stories about the healthcare provider feeling a little inadequate and then basically shames the woman. that maybe she doesn't need this or whatnot, or tells her, I'm the doctor, you know, I should tell you what you should need. And the person is saying and trying to advocate for themselves that I need this. I don't know what my partner's doing. Oh, you're going to be fine. You're going to be all right. And then honestly, I've heard in two women who have told me, which left me in tears, both of them were raped and they had no idea about the post, and no one told them. They did the rape kit, they went through the whole 9 yards, they, you know, all of the shame of that, and were not told in that moment that there was something that they could have done to ease their worries. So, you know, I really hope that with PrEP and with post that we can educate our healthcare providers, also educate those who will be a part of those situations like rape, maybe our police officers and things of that nature in our community, to let them know this is not a shameful thing. This is no more than you taking, you know, your diabetes medication or whatever you need to happen. It is a medication that can prevent something from occurring. That's it. The shame and the stigma that, you know, people have addressing around it, that's the part that I think that needs to leave for us to have something happen, where we
That's
have
great.
some kind of breakthrough, where
That's
we have
great.
so many cases to be, you know, decreased.
It sounds like education on all levels, providers, patients themselves, the community are needed at all those levels. So that's a great take-home message, and something where social workers can really fill that gap as well. I'm going to stop because we've got time for one more point around stigma. Gina and DAFINA, I'm going to want y'all to end it up and really kind of give us some hope about this stigma thing, maybe some strategies that you've seen that might work. Of course, we Gina and myself have worked with churches around trying to decrease stigma. So I'm going to give it, Gina, you start, and we'll let DAFINA bring up the rear.
So the first thing to remember about stigma is that it's not an apple. It's not a one bite thing. It's an onion. It has many, many layers. Sometimes it could be that we're stigmatized because of our HIV, or because the fact that I'm poor and I'm Black and I'm living in the South and I was in a domestic violent relationship. So it could be a whole lot of other things, and we have to address them as they come up. One thing that we're doing at SAC, DAFINA know I love to talk about Lead Academy. Our Lead Academy is Leadership Education and Advocacy Development. And we have a Unity workshop, and both of those are really, Unity really looks at stigma. So we do stigma triggering videos, and we have deep discussion about it, because we know that for the most part, people living with HIV, we don't get to talk about that stigma. We don't get to talk about the time we were at work and we left out the bathroom and we left something and went right back in and we smell bleach, you know, and one of our coworkers was in there bleaching the bathroom down. Or the time when we were at work and everybody was going out to lunch and you wanted to join them, and because you're the person that with HIV, you're not invited. So those things happen, and we get people to talk about it in a real way. One thing about SAG that I really, really love is that we do recognize that stigma is that thing that's debilitating. It is the thing that's keeping people out of care, keeping people from having optimal health outcomes. And it's also sending some of our people back to the street, you know, to self-medicate. So we're trying to not put a Band-Aid on stigma. We're really trying to address it, cut it out if we have to, and then rebuild the person, work with them on rebuilding themselves. And we always start with language. We never say, and this is for everybody, not trying to pick on anybody, but we never say HIV positive. We always say living with. We put people first. We use people first language, because that's what it's about, addressing the person, not the HIV. That person comes first.
Thank you. Thank you for that lesson, Gina. We need it.
I'll just add to that, you know, it's going to be really critical in addressing and changing HIV. And I do have hope. I am perpetually optimistic, even in the face of all the crazy. But in order for us to truly change this dynamic and to end the stigma and the shame, we have to de-silo HIV. We have to stop just talking about HIV and deal with the full range of experience that folks are having. And what that means, even in this conversation about PrEP, is that, you know, someone mentioned the follow-up that's required, the regular clinical follow-up that's required when you're taking PrEP. That means that your primary care doctor should know something about PrEP. For women or those who can get pregnant, it is about also getting a pregnancy test routinely, which means your gynecologist or whoever it is you see around your reproductive health should know about PrEP and PEP and the full range of HIV prevention tools that are available to us. So it's also about supporting policy change in the region and across the country that is going to end stigma. So it's about ending a criminalization of HIV, which is particularly harmful in southern states where folks are criminalized and can be charged with felonies for sexual encounters with someone who claims that it was, intentionally trying to transmit HIV to me and some other diseases as well. So we have to start having these conversations. Right now at SAC, we're working with an organization in a southern state on having PEP, the post-exposure prophylaxis, readily available through prescription by pharmacists, which would mean you can go to your pharmacy and get PEP, just like you get Plan B because you think you might get pregnant after the night you had. And so it's the same thing. So why don't we stigmatize Plan B? In some spaces, folks still feel some level of, shame or stigma when they have to go into the pharmacy and get that. But so just recognizing that there are policy changes that are happening that we have to continue to push for, that it has to happen. And it's also about your everyday interactions. People are always listening. Person first language is important. As I was telling the story of my friend who has since passed away, she saw what I was saying publicly about HIV, which made her feel comfortable to come and speak with me. So what you project and what you put out into the world, particularly as a social worker, the way you talk about people, the way you speak about folks' conditions, all of that can either perpetuate stigma or it can perpetuate hope. And so it's really important and critical around our language and critical that we listen to people, because what's stigmatizing for you may not be stigmatizing for the other person and vice versa. So recognizing the subjectivity of that and being respectful of that and meeting people where they are and addressing what is harmful to them in their circumstances.
So I thank the panelists. I want to thank each and every one of you for your contributions. I've got a couple of one-liners here that I'm going to end with, and we've got to kind of maybe use social media to ding these throughout the day. DAFINA Award said, de-silo HIV, deal with the full range of experience in which people are having. Gina Brown said, HIV stigma is not an apple, it is an onion. Ms. Wilkes said, social workers are essential. I think Gina said people first language is important. So just a phenomenal job. And thank y'all all for all those one-liners and our zingers and take home messages for today. And I'm going to turn it over to, can't remember who, but I'm taking my virtual mic and passing it on to somebody I'm supposed to pass it on to.
Thank you, Dr. Foster.
Yes.
Wow is all I can say. Wow, so amazing. Such an awesome panel. I have been touched by it, and I am sure that our audience has been touched as well. And so, Dr. Foster, thank you for moderating such great conversation. Gina, thank you for unveiling yourself and for sharing your story. And I agree, it's about people. And as social workers, we can take a lot, from this conversation, because we all look at the micro, macro, and the meso systems. And from the macro perspective, we think about people, we work with individual. And from that meso, we work, with groups and in communities. And then Dr. Johnson and Dr. ZENORIA PRUITT talked about research, and they did not make it scary. And, and research is so much fun when I hear from your perspectives. And so Dr. DAFINA, and that was prophetic. And so she is an attorney, but that was prophetic. So Dr. DAFINA, thank you for sharing your stories. I'm not sure how I went. Can you hear me? If you can hear, okay. And so, okay, I'm not sure how I hopped back on, but Dr. Russ, I want to turn it over to Dr. Rusty Bennett. He's from Collaborative Solution. He's going to talk about an upcoming event that they're hosting. Dr. Bennett, are you present?
I am. How are you?
Perfect. Thank you for joining us today.
Thank you. And thanks to all the panelists. As a alum of UA School of Social Work and also adjunct faculty member, y'all did fabulous. Thank you for that. We also are a good partner with SAC, and GINA is part of our group and has done stuff with us in the past. But I just want to really quickly introduce you to the Professional Association of Social Workers in HIV and AIDS. We're a national association and also have a national conference. This year we will be virtual again due to COVID, and wanted to make you all aware of that. SHA'TERRA Johnson is on our board, and she just put in the chat message a link to the organization. SHA'TERRA, can you just say a word of welcome and how folks can become a member of the organization?
Yes, good afternoon, everyone. This was a wonderful panel discussion, and thank you for the invitation to attend. My name is SHA'TERRA Johnson. I am all the way in Texas and enjoying this wonderful session that you all have today, and happy Social Work Month, as well as National Women and Girls HIV/AIDS Awareness Day. So becoming a member of PASGY is something I'm very passionate about, especially with me being on the board and trying to make sure that social workers and social work students know about PASGY and get involved. And I also put the link to learn more about PASGY in the chat. I had a whole script, but I'm not going to do that. But I definitely just want to say my testimony with attending the National Conference on Social Work and HIV. It is one of the most dynamic conferences that social workers and allies who work in the HIV workforce can attend. It's a wonderful opportunity to network and share best practices with social workers across the country and internationally, because we have individuals that come from other countries to this conference. But it's our 33rd national conference. The information in regard to registration is on the PASGY website, as well as I want to also invite everyone to even look into membership of joining the Professional Association of Social Workers. Again, there's so much benefit to being a member of the association, from learning sessions and listening sessions and trainings through collaborative solutions. So please take some time out and click on those links that's in the chat to learn more about PASGY, as well as about the National Association, the National Conference on Social Work in HIV. Thank you for having me.
I also wanted to introduce Rachel Newmeyer is also on of our staff. So both SHA'TERRA, myself, and Rachel, we're all here to support your journey as social workers, and just would love for you to be a part to continue these networking opportunities. But again, thank you to the panel, and thank you for extending and letting us to tell you a little bit about PASGY as a resource, and hopefully that'll be beneficial to you in your work as a social worker. Thank you, Ms. Wilkes.
Thank you so much, Dr. Bennett. And so again, to our amazing panelists, we thank you so much, Dr. Foster. We thank you so much. And to our attendees, this would not have been possible without you joining us today. And I know so many of you are excited about CEUs. So I will turn the mic over to Peggy SWAILS, and she'll tell you all about how you can earn your CEU for today.
Great, thank you, Sharon. So, gosh, again, echoing what everybody has said, this has been amazing. I have learned so much, so I appreciate everything that everybody contributed. I'm a continuing education coordinator with the School of Social Work. So you will be receiving one contact hour for today's presentation. I'm going to go ahead in the email that you'll receive the program evaluation. We'll ask you to, fill that out as well. And then you'll get your CEU form. But I'm also going to compile all of the information that's been shared in terms of, the PASGY, the conference, the panelists, all of their contact information with everybody's permission. But I think it'd be great for you to have as well if you aren't able to, if you've called in and you're not able to access the chat and get that information. So we'll include that in the email that you'll receive with your CEU. So again, thank you to Sharon for helping facilitate this and coordinate it. Thank you.
Okay, thanks again. And anyone last, we have about 2 minutes. If I can get maybe DAFINA, GINA, ZENORIA, Dr. Johnson, either one of y'all, if you can just give one word of hope for today. One word of hope. And I'll go first, because this is Social Work Month. And I say social workers are essential. And if you can say that to yourself, I am essential, write it on your wall, write it on your doorpost, write it on your windows, whatever role you play in the profession, remember that you are essential. And so I'll pass the mic to DAFINA, Dr. Pamela, or whomever would like to hop on to just give one word of hope. We have about 2 minutes left.
I'll jump in and say possibilities, that there are always possibilities. So no matter how hopeless it may look for yourself personally, because it's hard, especially right now, and also those that you serve, like change, growth, evolution, it's always possible.
I'll say social workers lead from the front. There are so many movements, whether HIV specific or otherwise, where you have social workers at every level of practice intervention, microspheres, meso and macrospheres, leading from the front. And I just love social work. I was born a little social work. I have it like branded somewhere on my body at birth. So we are indeed essential.
And I'll say intentional. Be intentional as social workers. And every day start your day knowing that you're not going there to fix anyone. You're going to help people fix themselves.
And I think I will say each story matters. Every single story, every single person matters. And as social workers, you are the caretaker of those stories. You are the ones who are the legs and feet of that story. You hear it and you're able to cause something positive to happen from that story. So please don't think anything like this is not important, because those are these people's stories. These is people's lives. And the fact that you have the ability to impact those lives, I think that's a special thing that should never be taken lightly.
I would say self-care. I really want to push self-care for not those only persons living with HIV, but those of us who take care and advocate for them. All of us need to really pay attention to ourselves, especially during this pandemic, really taking care of our health and wellness.
Thank you. And I'm going to push it a little farther. Morion, can you give us your one word?
I think someone probably already said this, but possibility. Just always remember there's a possibility for everything, and just keep that in mind when you're working with clients, patients, whoever.
Thank you. And I just have to say there's always someone in the background working, and this could not have been done without the support of our awesome communications team with David and Lindsay and Morion and Peggy, who also served as host, and for Dr. TRAYLOR, who's always supporting our program, and also in the absence of our own interim dean Reed and Dr. Javonda Williams. So, you know, we missed them today, but thank you again to our esteemed panelists, moderator, and for our attendees. This program would not have been successful without your support. And thank you, and we look forward to you joining our next panel discussion. It will be on March 24th. We will talk about macro social workers are essential. And we're talking about it from a more of a macro perspective when we're talking about communities and organizations and research. So register, you send it, you receive the information, or just reach out to us. And March 24th, save the date, March 24th at 12 noon Central Time. And until then, have a great day. And remember, you are essential. Social worker or non-social worker, you are essential. Thank you.